very, very much. Muchas gracias. Unfortunately, I don't speak any word or few words in Spanish. My English is very easy to understand. I would like to thank very much Dr. Chavez for inviting me and for this very active session. Well attended, and I would like underline the quality of the previous talk. It's difficult to follow such outstanding talk, but I will try my best. What is intestinal failure? First, it's a definition. It's defined as the inability of the GI tract to provide sufficient digestion and absorption capacities to cover nutritional requirements for growth and development of the child, and that requires parenteral nutrition. Intestinal failure is associated with parenteral nutrition. It's not intestinal insufficiency as defined recently by an expert group of adult gastroenterologists. In the past, it was the first concern implementing pediatric parenteral nutrition, increasing the indication for parenteral nutrition, and saving life of many children all around the world. We developed in Europe, at least in the early 80s, home parenteral nutrition, and in the early 90s, intestinal transplantation. This century has offered already some new therapeutic options for the management of intestinal failure. But one of the first steps was in the past because of the concern of parenteral nutrition-related complications, including technical complications involving catheter, infusion, pump, etc. Also, and it's a remaining problem, catheter-related infection, deep venous thrombosis, and finally end-stage liver cirrhosis, impeding the continuation of parenteral nutrition. And indeed, morbidity and mortality induced doubt in the long-term safety of parenteral nutrition, justifying alternatives such as intestinal transplantation. And indeed, many centers all around the world, including Latin America, start with intestinal transplantation. We start by ourselves in '87. And the number of intestinal transplantation performed all around the world, both in adult and pediatric patients, including or not the liver, was increasing until 2007. But afterward, it changed. And in the meantime, we developed the concept of intestinal failure and intestinal rehabilitation. And interestingly, we have a book written, edited by Eamon Quigley, who is attending this meeting, also Kelly Tependen and Alan Langdas and myself, joining intestinal failure in diagnosis, management, and transplantation. And it's very fortunate that the surgeon did recognize that intestinal failure is not only a surgical topic. And indeed, intestinal failure justify or oblige to a medico-surgical management together with pediatric GI and nutritionist and pediatric surgeon, because the purpose, according to the duration of the intestinal failure, can be surgical or medical or both. But to my position of medical doctor, non-surgeon doctor, the intestinal failure concept, together with parenteral nutrition, allow us to develop the diagnosis and the management of several very important rare digestive conditions like short bowel syndrome, congenital enteropathies, or neuromuscular disease. And today, the intestinal rehabilitation concept is adopted. And if you look at the literature, there is a growing number of papers involving the concept of intestinal rehabilitation, which is based on the collaboration between pediatrician and surgeon, and also dietitian, social worker, etc., etc. On the side of parenteral nutrition, we published in 2005 the first guideline, and the second one will be, I hope, very soon available next year probably. The cause of intestinal failure in children are congenital enteropathy, not all, but some, neuromuscular intestinal disease, and short bowel syndrome. There are very, very distinct situations with different degree of intestinal failure, achieving different course of high intestinal failure. That is just for summarizing the panel of disease causing severe neonatal or very early onset diarrhea. And according to the clinical presentation, to the family background, to the prenatal symptoms, we are able today, just from clinical analysis, to point on the diagnosis of congenital enteropathy. But what changed during the last decade is the knowledge of gene mutation involved in many of these enteropathies that does not change the prognosis, but that change a bit the management. And one of the first neuromuscular intestinal conditions is characterized by chronic intestinal pseudo-obstruction syndrome, which is characterized by a repetitive episode of continuous symptoms and signs of bowel obstruction, including radiographic documentation of dilated bowel in the absence of the fixed lumen occluding lesion. It's a very, very severe disease, which onset is early in life for most patients before 1 year of age. And the condition of the patient is very poor, since we are obliged to insert a gastric tube, a G tube sometimes, and to perform ileostomy in all cases, impairing the life and the quality of life of the patient, and that could be an indication for intestinal transplantation because of parenteral nutrition limits and poor quality of life. And this work showed that there is a huge and significant difference in self-care, mobility, school social activities, and pain-free between normal, healthy children and chronic intestinal pseudo-obstruction children, with decreased self-esteem and increased anxiety for both the parents and the patient. SIPOS require team effort involving many professionals, including dietitian, nutritionist, psychologist, social worker, and any other subspecialist, since the disease is very severe. Criteria for performing SIPOS in transplantation is permanent intestinal failure, poor quality of life for a child and the family. And permanent intestinal failure is associated for most with daily gastric aspiration, high level of parenteral nutrition dependency, and onset of parenteral nutrition and intestinal failure related complication. And if you look in our experience, out of 253 patients, we perform very few intestinal transplantation, but the current result of intestinal transplantation are poor, and we are exactly fitting with the result reported by the intestinal registry last year, which is below 50% at 5 and 10 years of follow-up. And the third condition causing intestinal failure is short bowel syndrome. There is many phases of short bowel syndrome according to the cause, from necrotizing enterolitis to midgut volvulus, including also gastroschisis, intestinal atresia of different form. That means that any short bowel syndrome should be defined not only on the length, but also on the anatomy. The definition of SBS is a clinical condition characterized by malabsorption and rapid transit after more or less extensive rejection of the small intestine and requiring parenteral nutrition. It is very important to consider today the anatomy. The type 1 is the one without colon and with a permanent jejunostomy. The type 2 is represented by jejunocolic anastomosis with loss of part of the colon. And the type 3, which is the best, is characterized by the preservation of both the anterior colon, the terminal ileum, and the ileocecal valve. And you can believe me, it changed totally the prognosis on the long term. And the physiological process of intestinal adaptation is based on the lengthening, but also the dilatation of the remaining intestine in order to increase the internal surface, and finally the absorption surface. When it is enough, you can wean off parenteral nutrition, but it takes a long time, and this process of adaptation of the remnant intestine is conditioned by hormonal factors, and the first line hormone is from the enteroglucagon family and represented by GLP-2. The other peptides are very active, but the most important is GLP-2, together with luminal factors. And I do include in luminal factor IGF-1, because you know that IGF-1 is produced by the salivary gland, the pancreatic juice, and it's very important to stimulate the salivary gland during the process of adaptation. I would like to emphasize the importance of the colon. The colon is a very crucial organ in the process of adaptation, as shown by the hypertrophy of the colonic mucosa, shown by my colleague and friend Francesca Joly a few years ago. And if you compare the mucosa of SBS and control, there is a significant difference. And the message are, colon plays a major role by reducing time of parenteral nutrition weaning, by improving diet, energy salvage. Hyperplasia of colonic mucosa and colonic microbiota are crucial. And we have in our practice to preserve as much the microbiota in avoiding excessive antibiotic use and to promote the production of short-chain fatty acid and growth factor. Indeed, the carbohydrates undigested on the level of the small bowel are digested and recycled to produce short-chain fatty acid. And those short-chain fatty acids are a very, very important trophic factor in stimulating, through the butyrate especially, the release of GLP-2. That means there is a link between colon, microbiota, butyrate, and GLP-2. No colon, very few, very low GLP-2. As shown in that study by Jepensen, which showed that in patients of type 1 without colon, according to the control, the GLP-2 plasma level are very low. Conversely, if you look at patients on type 2 with preserved of part colon, the GLP-2 plasma level are higher than in control, suggesting that the colon is able to promote the GLP-2 release. And the main message is that intestinal microbiota, it's a partner of adaptation and should be respected. However, there are negative effects related to intestinal microbiota in terms of oxalic lytases, delactic acidosis, very rare in children, anastomotic ulceration, and small intestinal bacterial overgrowth. And I would like to point the question of small intestinal bacterial overgrowth. I appreciate very much the view of the previous speaker, but I do consider that the main cause of intestinal failure-related liver disease is SIBO. And the aim of management is to avoid it. The aim for short bowel syndrome is to maintain growth and development, to encourage intestinal adaptation, to establish oral better than enteral tube feeding, to improve quality of life with home parenteral nutrition, to prevent and to treat complications, including catheter-related sepsis, venous thrombosis, high FALD, and bone disease. We have to promote and develop individualized strategy because many differences are between patients, underlying cause of SBS, anatomy and bowel length, number of surgical procedures, motility of the remnant intestine. I promote adapted strategy by respecting physiology. And the type and the mode of delivery of diet are not evidence-based, and they are much more based on experience rather than evidence. In our practice, the best program for a child with short bowel syndrome is first parenteral nutrition to have an optimal nutritional status, to avoid gut overload, to perform cyclic parenteral nutrition, preventing sepsis, and managing at home. Associated all the time with oral feeding because it is much more physiological, with the release of EGF from the salivary gland, by the self-regulation of intakes, by promoting digestive secretion, by improving the balance between fasting and feeding period, by promoting the gut bacterial clearance and preventing eating disorder. And our clinical management is oral feeding, hydrolysate also, the role of fiber to promote intestinal microbiota, short-chain fatty acid production, and finally it's much more experienced than evidence-based. And if you look in the literature, it's clear that the prognosis factor in short bowel syndrome are as follows in terms of survival. It's related to the onset of cholestasis and to the delay for performing the primary anastomosis. And the duration of parenteral nutrition is conditioned by the length, as we show in that more recent paper, showing that when you have the longest short bowel in green and you have the shortest in blue, the time duration of parenteral nutrition are not the same. Survival is almost 100%, but the duration of parenteral nutrition is very long for some, if not forever. And the long-term dependency can be changed by performing hormonal therapy, autologous bowel surgery, or intestinal transplantation. We have published a trial by using growth hormone, but unfortunately this growth hormone was able to increase during the treatment duration the citrulline plasma level, but as soon as we stopped the GH administration, the citrulline plasma level went back to the initial level. The hope today is by using the GLP-2 analog called teduglutide, that has shown efficiency in adult patients in short bowel syndrome in reducing the amount, the volume, and the number of calories delivered by parenteral nutrition at the dosage of 0.05 milligram per kilo per day. Recently was published the first trial in pediatric patients showing that during the period of administration of GLP-2 analog, you may be able to decrease the parenteral nutrition. But as soon as you stop the treatment, you go back to the initial starting point. That means that teduglutide can assist intestinal adaptation in children who have reached a plateau in intestinal function if used in an intestinal rehabilitation center by multidisciplinary team support. The long-term use appears to be beneficial, but is very costful. In our practice, we published last year during the international meeting on intestinal transplantation, this result showing the type 1, type 2, type 3 in terms of duration of parenteral nutrition dependency according to the type. And what we have seen is that there is for type 1 like a plateau, and for type 3 there is a decrease, and within 4 years 85% of the patients are weaned off parenteral nutrition. And the question today is how to use GLP-2 analog by reducing parenteral nutrition in those with type 1, by reducing or maybe parenteral nutrition wean in this group 2, type 2A or B, according to the length, or to use it very early in life. I disagree with the use early in life because it's too early and not necessary because we have the process, the physiological process of adaptation with us. After 4 years, the physiological process is not stopped but is very, very weak. Intestinal liver disease was very well covered by the previous speaker, but I would like to point on a very important factor, which is the report by the Toronto group showing that the main cause of mortality in their experience is related to short bowel syndrome and caused by liver disease. And it's well known that liver disease is related to the high incidence of fecal origin of bacteria that cause sepsis. And if you look at this US collaborative studies involving 272 infants, with, for most, short bowel syndrome from neck, gastroschisis, atresia, volvulus, long segment Hirschsprung disease. And the results are absolutely unbelievable. They show that only less than half of patients achieve enteral autonomy within 5 years. 1/4 die, and 1/4 require intestinal transplantation, and mostly related to liver disease. And one of the main causes is the rate of catheter-related sepsis, which is one of the highest I have never heard about. Almost 8 new catheter-related bloodstream infection for 1,000 days of parenteral nutrition. We are at that time in our practice below 1. And what is the main cause? The main cause, and I was very, very happy to have this cartoon in the front page of Journal of Parenteral Nutrition, of Journal of Pediatric Gastroenterology and Nutrition. It summarized the main cause of high FALD. Indeed, if you have a child with poor motility disorder, with dilated loop and subsequent intraluminal bacterial overgrowth, you may have very, very severe clinical symptoms, including nausea, vomiting, abdominal pain, but also you have a mucosal injury causing venous atrophy, malabsorption, increased permeability, and in turn, food allergy, eating disorder, and poor growth. But on the other side, you have, because of intestinal permeability, a translocation both of LPS and enterotoxic gram-negative bacteria, and that causes portal inflammation. And it's well established that there is a clear relationship between LPS reaching the liver, portal inflammation, fibrosis, and finally cirrhosis. And by avoiding SIBO, we may avoid liver disease. But another tool was mentioned by the previous speaker is to use the new generation of lipid emulsion. And indeed in Europe, and I hope as well in Mexico, we have many, many lipid emulsion available, including the new one containing fish oil. And in summary, I published this cartoon, showing that by using fish oil, you decrease inflammation by providing omega-3. You increase antioxidant activity by providing huge amount of alpha-tocopherol. You deliver lower phytosterol content, and you increase the bile flow. The soybean-based lipid emulsion do exactly the inverse. But we have to know that fish oil-based lipid emulsion may prevent cholestasis or reverse even high FALD, but does not reverse fibrosis. By performing autologous bowel surgery, you may achieve a gain in intestinal autonomy. You know very well the two main procedures for achieving non-transplant surgery, which is lengthening by intestinal tapering and lengthening, and by the serial transverse enteroplasty, which is largely used in US, while the LILT is widely used in Europe. And interestingly, it was reported by the Toronto group, the experience by performing STEP in patients with atresia, neck, gastroschisis causing short bowel syndrome. And the results are very interesting, showing that after the procedure, the citrulline increase, suggesting a mucosal recovery by resuming small intestinal bacterial overgrowth. By resuming small intestinal bacterial overgrowth, you make the mucosa recovering, you increase the intestinal capacity of absorption, and you gain in parenteral nutrition dependency. And it's demonstrated in the same study by the decrease in the fecal fat losses following the surgery. That means non-transplant surgery is also a tool in improving intestinal failure. And as a matter of fact, if you combine better management, prevention of sepsis, non-transplant surgery, and fish oil-based lipid emulsion, you may avoid the onset of any liver disease. In our experience, liver disease is almost not known, very, very few. We are facing with in patients referred to us for intestinal or liver intestine transplantation. And if you look in our experience of the past, if you compare home parenteral nutrition patient in red and intestinal transplant patient, the survival is almost 100% in those remaining on home parenteral nutrition, while those who have been transplanted because of nutritional failure meaning end-stage liver disease or advanced liver disease and extensive thrombosis. That means the prognosis after intestinal transplantation is as poor that we stop to transplant isolated small bowel. We always transplant with the liver and in case of nutritional failure. And for the future, we hope that the prenatal diagnosis of inherited disease will be very, very daily practice. Hormonal therapy for short bowel syndrome should improve the outcome. Intestinal transplantation require improvement, especially in donor-specific antigen approach. Tissue engineering might be available once for SBS. Stem cell transplantation for congenital enteropathies and Hirschsprung disease. Intestinal pacemaker insertion for SIPOS. And intestinal microbiome science for SBS and SIPOS. Thank you. Muchas gracias por su atención.